There was some updates on some data for zanubrutinib in relapsed CLL. This was updated at the Lugano meetings. Big study in CLL, a few hundred patients, and it's clear that zanubrutinib is very active in CLL, high response rates, over 90%. Like with other BTK inhibitors, most of those responses are partial remissions. The safety and side effect profile looked very reasonable, pretty comparable to other BTK inhibitors. Hard to tell right now whether it's better or worse, just the same. But I think the point here is that we're going to have large data sets for zanubrutinib in relapsed CLL relatively soon in publication, and then we'll really be able to look at that data and make a determination whether this new BTK inhibitors offer any advantages over what we already have. I think it's possible that zanubrutinib could receive approvals for use in chronic lymphocytic leukemia at some point. There's a large frontline study that's currently being conducted, a global study comparing zanubrutinib against standard BR therapy. And if zanubrutinib performs well in that study, it could get a frontline indication in CLL. And then there are some large relapse refractory experiences going on around the world. It could also get an indication in those settings. And if it does get FDA indications, then the decision for clinicians is going to be which BTK inhibitor to use. Do I use ibrutinib? Do I use acalabrutinib, assuming acalabrutinib gets an approval in CLL? Or do I use zanubrutinib, assuming zanubrutinib gets an approval? And at this point, I'm not prepared to say, which one is going to be used more often. I think it'll depend on the specific FDA indications. I think it'll depend on a closer look at the safety profiles, the side effect profiles. And even now, there could start to be some pricing issues. These are oral drugs. They're very expensive. And sometimes there's significant out-of-pocket expense for patients, large copays. So if you're a clinician like me, who's in the trenches treating patients all the time, and you're dealing with this in your clinic where you'd like to start a patient on a BTK inhibitor, but they have a huge problem affording the medicine, it would be great if we got some price competition in the field to help drive the cost of these drugs down. So a lot of us would really like to see these drugs become more affordable for our patients. We did get an update on acalabrutinib used as initial treatment in CLL at the ASH meetings this year. It was a frontline trial with almost 100 patients, and the activity is remarkable in the frontline setting. The response rate was 97%. At 3 years, the duration of remission was over 95%. Very few patients had to come off for toxicity or AEs. Like with all BTK inhibitors, there are some toxicities, so patients did experience some degree of headache, which is a unique side effect for acalabrutinib. You don't see as much with ibrutinib. Diarrhea, arthralgias, myalgias, bleeding. But when BTK inhibitors are used as initial treatment in CLL, the activity is remarkable. The ability to control the disease is truly remarkable. And over 90% of patients will still be on therapy in remission out 2 or 3 years when they start BTK inhibition as their initial form of therapy.